Hello, doctors. Hello. I hope everyone is well, and I hope your journey for Plab2 exam so far is going smooth. I will mute you guys initially, and I will let you ask questions at the end of our free session. All right. Doctors, just a brief introduction. I am an A&E doctor working in the UK. I've also been teaching for Plab2 OSCE exam for past 1.5 years or so. I do run a recorded course, as well as I do conduct one-to-one live mock sessions as well. As many of you may know, some of you who do not know me, just a brief introduction. All right. So the recorded course is running very successfully, very good passing rate. And yeah, I mean, you can ask me questions at the end of this session if at all you're interested. All right. Okay, doctors. So doctors, to begin with, let me see if we have some more doctors joining. Or okay, right. Because sometimes what happens is that some doctors join afterwards and then they want me to start over again from the beginning, which becomes a little bit challenging. All right, doctors. So doctors, a little bit introduction about some of us. We are, some of us already know what a Simman station is, and some of us, when we land into this world of Plab2 exam, we have no idea what is this Simman, a man which can simulate like a real human being. Okay, now the importance, I, to be honest, when I started my journey, when I attended an academy, no one ever told me that what is the purpose of bringing this person, this human who is actually, because if there are other stations where they are actually presenting with some presenting complaint, why this person, this statue, this dummy who can speak, who has pulses, who has heart sounds, who has lung sounds, why this one has to be there? Okay, I always tell my doctors as well, whenever I conduct mock sessions, whenever I'm teaching them my Plab during our Plab2 course, I tell them that please, you will not be successful in this exam if you are not asking yourself questions. For example, when you are taking history of an ethical station or diagnosis station, if you ask yourself that why am I asking this certain set of questions in this particular station, then it'll be much easier journey for you. No matter how many times you will buy hard things, they will just fly away, especially in this kind of intimidating exam. But if you have understood things properly, that what is the purpose of this thing, then it becomes much more easier for you. You are logical, your approach is logical. Okay. And hence the reason why I would want you to think that why Simman? The Simman is there because I'm sure we all know that all the patients there in our OSCE exams, they are just actors. Okay. The symptoms that they are presenting with, they are all made up symptoms. They are speaking a script. All right. But how to present a patient which is very unwell? Now, it is very hard to simulate symptoms of an unwell patient. Okay. Because if obviously, if they may present to you a patient who's probably saying, presenting with an acute abdomen, you might also just start treating them. You might also just start wanting to, start some fluids for them, for example. Or you might want to give them IV analgesia or IV anti-sickness because they are throwing up in front of you. They are vomiting in front of you. So to avoid that kind of a hassle, there are Simman stations. person who you can give IV fluids, a person who you can listen to heart sounds. Now, it is really difficult to present a specific heart sound or a lung sound in a real person. How can they give you crackles if they want to present a pneumonia patient to you, a septic patient to you, where the focal of initial infection was actually in lungs? But they can do that in a Simman station. So that's the whole purpose. So I hope from this whole 5 minutes discussion, you guys have understood, you all doctors, my wonderful, wonderful doctors have understood that Simman station means somebody who's acutely ill. Okay. Right. Let me just mute everybody because some doctors like to. Okay. All right. Okay, doctors. So go with that mindset that any patient presenting in a Simman station is going to be acutely ill. So be extra careful. Okay. Be prepared for that scenario so that you don't kill that person. Okay. So act as a safe doctor. Now, the key to acting as a safe doctor in a Simman station. Doctors, if I put my whole discussion in a nutshell, okay, or one takeaway point, if I want to give you at the beginning of this session, is that know your ABCDE well, okay? Know your ABCDE approach well. If you know that approach, your patient will not die. So they are not looking for a doctor, a specialist doctor, a consultant who can actually manage a patient with, for example, postpartum hemorrhage, or a specialist, a cardiologist who can manage ACS, acute coronary syndrome in a patient. They are not looking for consultants, my dear doctors. They are looking for junior doctors who know their airway, their breathing, their circulation, disability, and exposure very well. So all you have to do to pass a Simman station is know your ABCDE well. All right. So if you know that well, you are a safe doctor. You're a safe junior doctor. Okay. So that's your takeaway home point. That all I have to know very well to pass a Simman station is my ABCDE. All right. Okay, doctors. Now, I'm just going to give you some points which are very, very essential when you're approaching a Simman station. Doctors, no need to buy hard these things. You just need to know these things, that this is something that I should make as a part of my personality, as a part of me as a doctor, if I want to succeed in a Simman station. All right. So the very first point is that treat the problems as you discover. All right. You will treat the problems in a Simman station as you discover them. Now, what do I mean by that? I mean to say, if I said to you that, doctors, you should know your ABCDE well, okay? Now you may come across a patient who is choking, or who is kind of producing a grunting sound, and an anaphylactic patient who may present like a gurgling sound or like a snoring sound. So that means their airway is not clear. Their airway has swelling. Okay, so you need to protect their airway. You need to maintain their airway. So you will not be a safe doctor if you identified the problem, but you moved on to your breathing. Okay, so you need to sort out the airway problem, and then only you will move to your breathing. All right. So, and we'll keep talking about this further. I'll explain to you, I'll give you more examples. What do I mean by this? Treat the problems as you come across them. So, for example, if you're assessing the airway, there is a problem in patient's airway, please make the interventions. Okay? Put on the interventions then and there. If you discovered, for example, in circulation that blood pressure was low, please correct it then and there. Okay? Correct it then and there. Don't leave it to the last minute that I'll give fluids to my patient. I'll give fluid challenge to my patient at the end because I have to do my management. Now, this is what academies make it, difficult for us to pass Simman stations particularly, because this is how we are taught for other stations, that you have to do the management in the end. And that's why you are waiting that maybe I'll give the fluids to my patient at the end. Maybe I'll start the oxygen at the end. Maybe I'll give the salbutamol to a patient who's wheezing. Maybe I'll give the salbutamol at the end. Okay? So treat the patient as you come across the problem. Okay? As you're doing airway problems, as you're identifying them, correct them then and there. All right, doctors? Okay. The next thing is that reassess regularly. Now, this is also a very, very important takeaway point. Sometimes many of my friends told me that, I went into a cement station and then patient's airway, patient started deteriorating and patient was dead and there was a flat line on the monitor. Why that happens? Because then they tend to change the patient's observations and you ignored it. Probably patient was continuously bleeding somewhere down there, but you have not gone on to exposure as yet, your E part as yet, and you have not seen the bleeding. But on the monitor, the blood pressure was dropping and you did not notice this. So another takeaway point is that please, if you have finished the airway and you're on breathing, please check on the airway again and say like this, is patient's airway patent? All right. So reassess regularly. All right. Okay, doctor. So the next point is work as a team. Work as a team. So they will notice this, doctors. If there is a nurse who handed over a patient to you, you're in a cement station, there is a nurse who asked you to review this patient and she's standing there. There is always, doctors, in Plab2 exam, every single thing they do, they say, their body language, so I call them verbal and non-verbal cues. There's always a purpose of any single object in the room, any single person in the room. Okay? So if the nurse is there, she's there to help you. So work as a team, involve her. So delegate the task to her. We'll talk about it in a minute, that how you will delegate the task to her. How will you ask her to help you? How every now and then you will involve her to help you. So please, these are the things. Delegate the task. Work as a team. They are trying to notice in cement stations that are you a doctor who will work in team? Because we back home, we are so used to of like, I'm the doctor, I'm, one soldier army, and I will do everything myself. I'll take bloods, I will put the patient on fluids, I'll do everything. So teamwork, doctors, keep that in mind, please. Okay. All right. So the next point is that make sure that patient is on a monitor. An unwell patient, as soon as you identify that patient, doctors, let me just mute again the doctors who have joined. All right. So you just want to make sure, as soon as you know that my patient, for example, what happens is that many times I am working in emergency department and I see some patient. If I give you an example, when a normal patient comes with diarrhea and vomiting, it's not something that is, very serious in emergency department. And we say, all right, okay, this patient has, come with the probably with diarrhea and vomiting, and it's most of the time it's viral, so he can sit in the waiting area. But one day I was examining this patient and he started fainting. His oxygen saturation level started dropping. I called the nurse quickly because as I was talking to him, he was going dizzy. He started closing his eye. And I identified that quickly. And I called the nurse and I told her that, can you start monitoring her? Can you check his vitals? As soon as we checked his oxygen saturation levels, we checked his blood pressure, it was very low. So we moved him straight away to a monitored bed. Okay. So put the patient on monitor, doctors, so that you can see continuously their blood pressure, their oxygen saturation levels, their ECG. Okay. So put the patient, as soon as you identify this patient is acutely unwell, put them on monitor. So if you know these points, you know your ABCDE, you are sorted for your Simman station. Okay. I'll tell you at the end my little story of Simman station. What happened to how when I attended the Simman section in academy, what really happened. But yeah, thanks to the online resources and everything, the amount of knowledge and information available online that you can self-teach yourself. All right, doctors. So moving on to the next part of our session, just keep these points in mind, doctors. Trust me, they will help you big time. All right. So what are you going to do? First of all, doctors, even in other stations, no matter how intimidating the situation is, okay, no matter how intimidating the situation is, for example, in a Breaking Bad News OSCE station, the patient might be standing in front of the door and asking about their son, their relative, okay, you always introduce yourself first. Okay. In the UK, it is considered, if you're part of an emergency team particularly, it's important that people know each other's name, because in an emergency situation, if you have ever been in one, you'll realize that how easy your life becomes if you know your team members' names. Okay. So that's why it's very, very important that you introduce yourself. Whoever is going to ask you to review the patient, you enter the cubicle. If there's no one there, you introduce yourself to the patient. But as you approach the patient, you will say, as soon as you notice that this is a Simman station, you say that I will, first of all, I will notice, I will see if it is safe to approach the patient, and then I will check for response. Okay. So you will say, you are just talking to yourself. You're talking to someone, invisible person or examiner. Okay. So you will say, as you step in the cubicle, you will say, I will check for safety. And if it is safe to approach the patient, someone might prompt you, it is safe to approach the patient, doctor. Okay. Even if they don't prompt you, just go ahead. All right. Now I will check for response. All right. And then you will introduce yourself. So you have said these two things, danger, and you've checked for response. But what if a nurse is there? So you introduce yourself to the nurse. Okay. If the nurse's name is already given outside the cubicle, to make yourself sound even more more confident, name the nurse. Call her with her name. Hello, Becky. Hi, this is Zasia, one of the doctors here today. How can I help? Doctor, I've got an acutely ill patient here. He's coming with abdominal pain, blah, 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 blah. Okay. So you introduced yourself and now she's handing over the patient to you and asking you to review. But I have told you the other way around as well. If there's no nurse, then how you approach. Okay. All right, doctors. Next step. I literally do the same thing in the course that I take baby steps with my doctors. I teach them like little kids. I don't mind. But at the end of my course, they're all pro. They know how to conduct a consultation in the end of the day. Okay? All right, doctors. So next step. Doctor, don't worry. We are going to the danger part again. Okay? Don't worry. All right, doctors. So I like to use this famous approach, which is used by most of the doctors and nurses in the UK. Okay, especially the doctors and nurses who work in the acute setting, okay, in acute medicine or in A&E department. All right, which is Dr. ABCDE. All right, so what does doctor stand for? So D is for danger. So you walked in, you literally imagine yourself that you're outside the cubicle, you just read the task statement, now you're stepping in the cubicle, you see that this is a Simman station, you just saw that big dummy on the table, you entered and you will say, I can see my patient, but is it safe to approach? Someone does not speak, you just approach. If someone prompts you, even better. So you're checking for danger. So you just proved yourself already that you're a safe doctor. That's exactly what NHS is looking for, a safe junior doctor. All right. Next step, doctors, response. So you saw that the patient is conscious. You went to him and you said, hello, Mr. John. This is Asya. I'm Asya, one of the doctors working in the emergency department today. How are you today? Doctors don't go on long introductions. All you need to know, you introduce yourself and you ask him, how are you today? That's it. Okay, that's it. All right, doctors. Fine. So you checked for danger, you checked for response, and patient spoke to you. Patient said, doctor, I'm just all right. Doctor, I've got a little bit of a pain here on left side on my chest. Or doctor, maybe the patient says, doctor, I have pain here in my right calf. Okay, so we are considering the scenario of, for example, acute coronary syndrome or acute limb ischemia. Okay, or doctor, I can't feel my right leg at all since yesterday or this morning, he says. All right, so you say, then afterwards, you've spoken to patient this much. How are you, Mr. John? And then he spoke to you, and then you said, my patient is talking in full sentences. His airway is clear. Okay, his airway is clear. All right. The other situations, doctors, what can happen? Patient could be grunting. Patient could be, making different sounds like snoring sound. Now that at this point, you don't really need that because then that becomes part of basic life support. Okay. And you don't really have a real life scenario like in your Plab2 exam where a patient is gone into arrest and then you do the basic life support as well. Okay. So mostly their airway might be patent. Okay. But just to let you know, just for your own information, if at all patient's airway is not patent and you hear any kind of sounds, then what will you do? Head tilt, chin lift. So you will tilt the patient's head, put your right hand on patient's forehead, imagine pushing it backwards, and then putting your middle finger and index finger underneath patient's chin and lifting it up. So head tilt, chin lift approach to make the airway clear. All right. You can just, when patient is talking, you can also say that there is no visible foreign body, no bleeding, no secretions, no visible secretions. All right. So you are a safe doctor. You ruled out that airway is clear. Doctors, when I explain things, now last time also I was asked this question, how do I finish this in 8 minutes? So doctors, if I was with you in real life, I would literally perform it and I'll tell you that how to finish it in 8 minutes. But because I'm explaining things to you, I'm giving you logics about everything, that's why it's taking longer. All right. So doctors, next step would be, after you've assessed patient's airway, next step would be breathing. All right. Assessing patient's breathing. Now, what are the things that we do to assess the breathing? All right. So doctors, this was the slide. As I said that, you introduce yourself, you tell your name, and you tell your role. I'm one of the doctors, I'm one of the FY2s, okay? And ask patient, how is he feeling?
How is the first thing to shut down the campus? How about addressing the current issues by taking proactive steps to reassure the students? This thing won't happen again, that's all. Or sanction some of the workers if that's what they want.
Okay,
Please
doctors,
give them
sorry about that. Let me mute.
Mistake.
Okay, right. Someone had some commotion going on in the background. All right, doctors. So we did that interaction part. After danger, we checked for a response. We introduced ourselves and we said, how are you feeling, Mr. John? Patient's airway was patent. And doctors, this is what I've already said to you, that if patient's airway is patent, patient will be talking to you in full sentences. And you will say that patient's talking in full sentences, my patient's airway is patent and no intervention is required at this point. And then you will move on to next step. Okay. These are some signs that I have written down for you, that, what you have to notice at while you're assessing the airway. Is there any cyanosis? Is there any seesaw breathing? Any use of accessory muscles? Any diminished breathing sounds? Okay, when you come near to the patient, you're talking to them. Any added sounds at all, like grunting, okay, snoring, for example, gurgling sound, for example, which shows that there are some secretions. All right. Okay, doctors, which might not be the case. All right, that might not be the case in for you in Plab2 exam. Patient's airway might be patent. All right, you can just move forward to next step. Now you may say that in a Simman, how do we see all of this? Someone in the background will say, patient is cyanosed. Patient is using accessory muscles. All right, so you'll get prompts. All right, doctors. Okay. So doctors, this is a further thing, which again, as I said, that in Plab2 exam, very rarely it happens that patient's airway is not patent. But in case it is not, you hear any sounds, any gurgling, then what interventions you need? Because as I said, every step you'll make the assessment, you'll see if any assessment is required. Okay. So look for any obstructions, any secretions, any foreign body. All right. And if you don't find them, what do you say? You verbalize it. Okay. You say patient is talking in full sentences. His airway is patent. There is no foreign body, no secretions, no added sounds. So I'm moving on to breathing. However, I may need to reassess the airway again. So doctors, nobody will tell you this every step. If you say this, however, I would like to reassess the airway again. However, I would like to reassess the breathing again. Every step, you are extra cautious, and the examiner is knowing that you are a safe doctor. Okay. If you are saying that right now, you might actually do it as well. Okay. All right. Okay, doctors. So you move on to your breathing, your B for breathing. So we are doing doctors ABCDE. So we checked for danger, we checked for response, we checked for airway. Now we are moving on to breathing, doctors. Okay. I like to use this mnemonic for this whenever I'm checking patients' breathing. RATS, R-A, or you can say rates, RATES. So you'll check the respiratory rate. So you will say, I would like to get my patient's respiratory rate. Now, I think that will be a very bad decision if you start checking patient's respiratory rate yourself. So how would you do it? You will just verbalize. Can I please get my patient's respiratory rate? Okay. Can I please get, so if the nurse is there, what will you tell her? Emma, can you please help me? Can I please get my patient's respiratory rate? Emma will tell you the respiratory rate. Okay. So can I please get my patient's respiratory rate? That will indicate that patient has tachypnea or not. Okay. All right. Then you will check for auscultation. Doctors, I don't advise you to do a full respiratory examination. If you want to really do it, just quickly inspect, say that there is some respiratory effort present. Okay. On inspection, there is some respiratory effort present. Okay. So, and then you can go on to auscultation. Okay. Check for respiratory rate, check for auscultation. So don't do auscultation of all the areas. At least 4 spots on the chest should be fine. Okay. You can do 2 anterior chest wall, 2 apical, 2 lung bases. If not more than 6 auscultations spots. Okay. So quickly auscultate the chest. And as you are auscultating, what you will say? Is there anything on auscultation? Okay. Is there anything on auscultation? They may say it, that there are crackles on auscultation. There is wheeze on auscultation if it is an asthma Simman, or you may actually hear it in Simman. You may actually hear the wheeze. You may actually hear the crackles. All right. Sometimes they can just prompt you as well. They can just say there is wheeze on auscultation. Okay. Or they can say there is some gurgling, or there is some craps on lower lobes, or one right lower lobe. Okay. Next part of your mnemonic of rates is T. So you can put your 3 fingers on the trachea, base of trachea. Okay. And then you can say, is trachea central? Okay. And then they can prompt you that trachea is central or not. All right. So what are you checking for at this point? You're checking for tension pneumothorax. All right. So you're safe, doctor. You are ruling out pneumonia here. You are ruling out any respiratory depression here. Okay. You're ruling out effort of breathing. Is patient becoming unconscious? Are they losing their respiratory effort? Okay. Increased or decreased respiratory effort. Okay. And then again, teamwork, doctors. Every now and then you will involve your team. Emma, can you please put on the saturation probe? Don't do everything yourself, doctors. Trust me. If a nurse is present, involve her continuously with you. Teamwork, teamwork. This is one of the actually marking criterias in the UK, whether it is interviews, whether it is exams, any medical exams. Teamwork is one of the things that they are looking for in you, especially in Simman stations. Because if a patient is acutely unwell, they want you to work in a team. So Emma, can you please put on the saturation probe on? What is the oxygen saturation like? Okay, check for oxygen saturation levels. All right. Doctors, if you identify any unwell patient at the very beginning, start oxygen. Okay, start oxygen at the beginning. All right. You can change the oxygen saturation levels at this step. But if you identified that my patient is not feeling well, just put on the oxygen. Okay. Say that I would like to, is my patient a non-smoker at all? Okay. Or does he have a smoker's cough? If they say no, then you just put him on 100% of oxygen. Okay. Via non-breathable mask. Okay. If the respiratory effort is present, via non-breathable face mask. All right. Okay, doctors. Now, since you are doing the breathing part, your last part is sending for ABGs and chest X-ray. You can tell the nurse, Emma, can you please request for a chest X-ray and get a sample for ABGs. Okay, get a sample for ABGs. All right. So doctors, this completes your breathing section. Now I will just quickly say it, that if I was in a Simman station, how would I quickly say it? Okay, so I will go and I will look at patient's chest. I'll expose the chest. I will say that, Mr. John, I'm just going to expose your chest for the purpose of examination. Okay, and then you will say, can I get please the respiratory rate of my patient? You will be prompted. Okay, now I would like to auscultate my patient's chest. Several points, auscultate it. Pretend that you are auscultating. Put actually your stethoscope on those points. Okay, are there any findings? No, doctor. Or maybe yes, doctor. Wheezy or crackles, for example. Okay, put your hands on trachea base. Okay, 3 fingers on trachea base and say, is my patient's trachea central? You're looking for what you're looking for? Tension pneumothorax. Exactly. All right, doctor. So then you will say, how is my patient's respiratory effort? They may prompt you. Patient is making good respiratory effort. Okay. Emma, can you please put the saturation probe on? Yes, doctor. What are the patient saturation levels, oxygen saturation levels like? Doctor, they are 96% on air. All right, no need to put the oxygen. We can take off the oxygen mask at the moment and we can move on. Okay. Doctor, patient's oxygen saturation levels are whatever, 96% on 10 liters of oxygen, 5 liters of oxygen. Okay, Emma, we'll maintain, please keep the patient connected to the oxygen mask and we'll reassess this again. Okay, so as you're moving to circulation, you have told Emma, can you please take an ABG sample for me from the patient, and as well as request for a chest X-ray, please. Okay, and then you move on to circulation. You will say, my patient's breathing is all right. No interventions are required at the moment. I'll move on forward. For example, trachea was not central, doctors. Trachea was not central, or maybe there was on reduced sounds or no sounds on auscultation at some area. Doctors, what intervention? Doctors, I'm unmuting you all. Tell me, what interventions do you need? Reduced sounds on auscultation, or no sounds in a particular area. Hyper resonant.
Needle decompression. I mean, if it is
doctors, yes, one of you just say to, like you are saying to the examiner, now I would like, Emma, can you please get me this? I'm going to do this. At this point, what is the intercourse, what is the point where you want to add, what you want to add, and what will be your permanent solution for this later on, who you want to involve. Please do the intervention, doctors. Who is doing it for me?
It looks like a pneumothorax. We will first decompress it using a needle. Then finally, we need to put a chest tube in it.
Yes, doctor, you're absolutely right. We will not we will. Emma, can you please get this for me? And we will put this on this. I'm going to decompress it by putting this at this certain point. Okay, so it's you who's doing it. Your messages should be clear to the team, doctors. Okay, if your communication is not clear, they will mark you down. If you say, we will do this at this point, we will do this, and then we will do that. No, Emma, can you please get me this? And then, because a decompression is required. Okay, please know the markings where you want to decompress. All right, and what would be your permanent intervention afterwards. Okay, Emma, can you also call the seniors at this point? We may need a permanent intervention later on. Okay, so doctors there, so that's what I meant. Doctors, on breathing, on auscultation. Now someone else is going to tell me who spoke earlier. Not that doctor is not going to speak now. Now I need another doctor who will make an intervention. So examiner prompt you, or maybe when you were doing auscultation on Simman, you actually heard wheezing on all over the chest, like really a whistling sound, really a whistling sound. What you want to do? Will you move on to circulation, or you want to do anything? You want to tell Emma anything, what you need? Doctors.
A non-rebreathable mask.
Okay.
Emma, can you get the nebulization max and let's nebulize those patients?
Well done, doctor. Well done, doctor. Very well done. That's amazing. So that's what I mean. Interventions. Can I please get some nebulizers, Emma? Can we please do 5 milligram of salbutamol via high flow oxygen over this much time? Okay, clear messages, doctor. How much salbutamol you want? Okay, and you want it at high flow oxygen, and you want it through nebulizer. Emma might get salbutamol. She might started giving the patient the puffs. Okay, so you want to tell Emma a clear message, what you want Emma to do. All right, if Emma is not there, who do you tell? You just talk in the air. Okay, I would like to give my patient at this point 5 milligram of salbutamol nebulized via 100% oxygen mask, whatever. Okay, so please make the interventions, and every time you verbalize as well that I will reassess my patient. Okay, so just auscultating once and just giving the nebulizer does not mean that you will not come back to breathing again. So you, as you move on to circulation, you will say to your team, if Emma is there, any nurse is there, ask Emma, Emma, how are we doing with airway? How's my patient's airway? Doctor, airway is patent. Emma, any problem with breathing? Doctor, breathing is fine. Okay, can you please keep an eye while I'm assessing patient circulation? So if no team member is there, you will verbalize, you'll say that at this point, I'll need my team's help. And while I'm assessing patient circulation, I will ask a team member. I will also be extra vigilant to keep an eye on the monitor, keep an eye on patient's airway and breathing, and I will assess, I'll move on to circulation. Okay. So doctor, I like to use this mnemonic for circulation, EBIC. I'm a very, very childish kind of a doctor who likes to make life easy for other doctors and for myself. Okay, so that you know when you are in that overwhelming situation, you know your mnemonic of Dr. ABCDE, you know your mnemonic of rats or rates, and you know when you come to circulation, you will know your mnemonic of EBIC. Okay, so at this point, when you're assessing the circulation, you can tell Emma, if you have not said to Emma initially that, Emma, can you please connect the patient to monitors? Now this is the time that you can ask her to connect to monitor. If you have not done it initially, this is another reminder. Okay, if Emma has done that initially, if you've already asked Emma to do connect the patient to monitor initially, doctors, two things in an unwell patient. Please, can I remind you? Unwell patient, start on oxygen. You can change it later when you have the saturation levels of the patient, when you can actually assess their saturation levels. You can stop it. Oxygen will not harm until unless they are, they are, there is a chance of retention, carbon dioxide retention. And who will be at risk of retention? Smokers, cough, COPD patients. Yeah. Okay. So at this point, you'll tell Emma, can you get a 12 lead ECG for the patient? Can you also please attach the defibrillator pads? Why defibrillator pads? You're a safe doctor. If at all this patient deteriorated, you'll be able to shock him. Okay. Can you please attach the ECG and defib pads to the patient? Okay. It's up to you, doctors, if you like to do defib pads, because in Plab2 exam, the BLS part is actually not. Your patient does not deteriorate. In some of the exams in the UK, patient does deteriorate, patient loses consciousness, patient dies. Okay, but in your Plab2 exam, rarely patient dies. So if you want to skip this part of attaching the defibrillation, you can do that. Okay, let me mute all again because I can hear some sounds. Okay, doctors. All right, doctors. Then you can ask Emma. If Emma is there, ask her, Emma, can you please put the wide bore IV cannula for the patient? Okay, or you can say, can you get the IV access? Now you're talking to a nurse. And even if you are not talking to a nurse, you're talking to the examiner, you're talking to your team. So it's okay to use medical jargons now because you're not talking to a patient. So they will not punish you at whatever occasions you are talking to your medical team or examiner. They will not punish you for using medical words, medical jargons. All right. So you can say that if Emma is not there, nurse is not there, you'll say, I will get my team's help at this point. I would want IV access. I would also like some bloods. Now, bloods, baseline bloods, please do them all. Okay? Do all bloods. All right? All bloods, routine baseline investigations. So one of you, if you come up and actually say to the examiner, I would like to send some bloods for my patient. Or you're saying to Emma, can you please send some bloods for the patient? And Emma says, which bloods do you want, doctor? Now, doctor is going to tell me, I'm Emma. One of you, I'm going to unmute you all. And one of you is going to tell Emma, what bloods do you want to send? You can use medical jargons, by the way, this time. Hello, anybody?
Would like to start.
Yes.
Emma, can you please send blood sample for full blood count? And we also take sample for molecular urea and creatinine.
Right, doctor, I'll do that. Do you want any other bloods, doctor?
Random blood sugar.
Mm-hmm.
Do a group and save. Liver function test.
Exactly,
Then
doctors.
cardiac enzymes.
Exactly. Amazing, doctors. You all are super. Okay. So you did the urine electrolytes. You did the full blood count, inflammatory markers. You did the kidney and liver function tests. You did the grouping and cross-matching. And you did what else? The creatinine, the cardiac enzymes. Okay. The troponins. Okay. Cardiac troponins, CK. So well done, doctors. That's amazing. Doctors, if you don't want to send the group and save right now, you can hold it and you can do it later. I'll tell you when you can send it if you want to hold it now. Or if at all you forgot it here, I'll tell you where to add it, where you actually can add it. And no one will punish you. All right? If you forgot group and save and arranging 6 units of blood. All right? I'll tell you where. All right, doctors. So we have told that to Emma to get the IV access, to start, to send some bloods, and we've asked her to take a 12-lead ECG. All right? Okay. Now you will do the capillary refill, doctors. Doctors, what is the best point to check the capillary refill? If you want options, I can give you options.
We get options, please.
All right. So finger at the level of heart, you'll hold patient's hand and bring it at the level of his heart, press his finger for 5 seconds, or press on his chest bone in the center of his sternum for 5 seconds or 10 seconds.
I feel it's at the breastbone, the center of the sternum.
Amazing. All right, doctors. And you literally count 1, 2, 3, 4, 5. Okay. And you'll say, my patient's capillary refill time is, and they will prompt you. Okay. Capillary refill, normal. All right. Doctors, then you will look at patients. How do my patient's mucous membranes look? Are there any drains? Is there any in situ catheter? Okay. So you will check that. You will say at this point, I will check if my patient has any drains, check for urine output. If at all there is any in situ catheter, I will also check my patient's mucous membrane. Okay. So that is your circulation completed, doctors. All right. Doctors, if at all, I'm going to mute you all again. I can hear some babies crying. Okay, doctors. So if at all we identified a problem here, doctors, if we identified a problem here in this point, as I said to you, do your airway breathing and circulation. And as you find problems, please sort them out then and there. For example, we found out that capillary refill time is increased more than 4 seconds or more than 5 seconds. Blood pressure is 80 by maybe 90 by 60. What you want to do? One of you, doctors.
Give IV fluids.
How much, doctor? How much? Dr. Tasmia, how much fluid?
Yeah, I think we start with 500 ml.
Oh, you've got an 80-year-old here. You've got an 80-year-old here. What you want to know?
Maybe his sodium status.
80-year-old with a previous cardiac history, with a previous chronic kidney disease.
That's complicated.
Sorry, we can hear you.
Doctors, please, I'm making this session interactive, but some of you just want your kids to listen to nursery rhymes. Okay, I've muted that doctor. Dr. Tasmia and another doctor, whoever was wanting to talk. What you want to assess in this 80-year-old?
We have an 80-year-old with a chronic kidney failure. In this kind of a
Yeah.
patient, you don't want to give too much fluid. So I want to make sure I'm out, but because of the status, I might just give 200 ml of normal saline because of the pulse that was going down.
Amazing, doctor. She has a cardiac history as well, doctor. Chronic heart failure. What you want to check on his chest, on her chest before you give her fluids?
Basal
I want to check
crepitation.
basal crepitations.
Amazing. So you say that, Emma, are there any basal crepitations? I would check on my patient's chest if there are any crepitations. Emma, because patient has a history of cardiac failure, we'll start with 250 ml of bolus. We'll reassess the circulation again, and we may give another bolus. But before that, we'll reassess the chest again, or listen or do the auscultation again. Okay? So safe doctors, play a safe doctor all the time, doctors. All right? So these are some examples, doctors, that you will identify the problems and you will keep correcting them as you go. Okay? All right, doctors. Now we came to the disability part, your ABCD disability part. Now, AFU. What is AFU, doctors? Any one of you knows? I'm sure most of you know.
GCS.
AFU. Yes, GCS. But what is the full form? This is a quick way of you doing Glasgow Coma Scale, because in an unwell patient, it is very difficult to check the Glasgow Coma Scale. So how do you quickly just assess patients' conscious levels?
We can say that, can you open your eyes for me and then keep it open for me, then probably check his pupillary reflex.
Right. Okay, doctor. So patient was talking to you, isn't it? So patient is alert. Okay. Patient might not be very well oriented, but patient might be alert. Okay. If they are not alert and they did not talk to you, but they were just making grunting sounds or maybe groaning sounds like so what is that? You'll say patient is verbal on my AFU scale. Patient is verbal. Okay. If patient responded to pain, you press on the orbital bone with your finger. Okay. Or maybe on the inner corner of the eyes. And the patient responded then. Patient was not alert. Patient did not have verbal response, but patient responded on pain. What will you verbalize? Patient is on pain. Patient is responding to pain on my AFU scale. Okay. But mostly in your Plab2 exam, patient is alert. Patient is not unconscious, because unconscious patient will need basic life support, which is obviously is not part of your, part of your, what you call it, Plab2 exam. All right. So A is alert, B is verbal response, and P is pain, and U is unresponsive. All right. Okay, doctors, your next step would be checking patients' pupils. You will just pretend that you are checking their pupils, and you will say, what are my patients' pupils like? Patients' pupils are reactive to light and normal size bilaterally, equal and reactive to light bilaterally, which is normal finding. Okay. Patients' pupils are responsive and reactive to light bilaterally. So you just pretend that you are checking the patient's pupillary reflex, and someone will prompt you. Patient's pupils normal, reactive to light, and equal bilaterally. All right. Emma, can you please check patient's BMs? Okay. Emma, can we please get patient's BMs done? Patient's blood sugar levels done. Okay. And patient's blood sugar levels are low, doctors. Who's going to treat this patient for hypoglycemia? Patient's blood sugar levels are 3, doctor. Who's going to manage it? Doctors, please respond. One of you has to manage this hypoglycemic patient, unwell. Doctors, anyone wants to interact? Blood glucose levels 3 or maybe 2.1.
We should push a bolus of 5% dextrose. Push a bolus of 5% dextrose.
No, we give 150 mils of 10% glucose dextrose water.
Emma, can you give this patient some 25 mils of 20% dextrose water?
But what if patient is taking oral? If patient is able to take oral?
20% glucose gel.
Yes, if patient is able to take
oral, then we offer them sweets like biscuits.
Fruit juice.
Glucogel, doctors, glucogel. In an acute setting, you give glucogel, all right, and check patient's glucose level in 10 minutes. Okay, if patient has not responded, then you go on to IV. Okay, you go on to IV, all right. And what will you give IV? You will give 100 to 150 to 160 ml of 10% glucose. So you will say, Emma, can you please administer intravenous glucose 150 ml of 10% glucose? Okay, 150 mLs of 10% glucose. Don't say 150 to 160 because this is kind of a mixed message. You don't want to give that kind of a message to your colleague. Give very clear messages. No approximate amounts, nothing like that. Okay, very clear messages, doctors. All right, doctors, next situation. Your patient's temperature is high. Doctors, patient temperature is 40. When you were on breathing, you also heard craps. Doctors, who's managing this patient? Acutely unwell. Who is managing? Hyperthermia with a focus at the lungs. There was craps. Who wants to manage this unwell patient? Temperature is 40.1. What you want to add to the bloods, doctor, at this point? The bloods that you have sent, what you want to add to them, and what
blood culture.
Sorry?
Blood culture.
Amazing. You want to add blood culture at this point. And you want to ask
lactate
Emma.
As well.
Exactly, doctor. You all are superb. All right, doctors. Now, what you want to ask Emma about bloods? Emma, is the full blood count back? Yes? Or you want to ask examiner, is the full blood count back? Why are you asking for white cell count, full blood count now? What problem?
To know if you need to give antibiotics.
Amazing, doctors. Now you are learning that you're correcting problems as you are going through your ABCDE. Is the Simman station difficult now? I'm sure it's not, because you're correcting the problems as you are going through them. All right, doctors, other situation, hypothermia. This unwell patient that you are assessing was found in a lake, or he was found by paramedics on the floor of his house. He had a fall and his temperature now is 34.0. What you want to do?
Can ask Emma to get a blanket.
Okay.
And also
what else?
Warm fluids.
Warm fluids, amazing, doctor. Both the good approaches. So warm fluids and blankets cover the patient because you want to reserve the body heat. You want to increase the temperature. All right, doctors. So your next part, your last part is exposure. All right. Now you will examine hypertone. This is where your scenario comes. Okay, let me mute all. Okay, doctors. So now is the time when a lady of postpartum hemorrhage will come. This is the time when a person with PR bleed, low blood pressure will come. Okay. Someone is with bleeding. Now you have exposed the patient and you're checking for rashes, you're checking for swollen calves. And when you were checking for swollen calves, you were also checking for peripheral pulses, doctors. Right. You found that peripheral pulses were absent. Patient leg is blue and cold. What you want to do? Who wants to manage this patient? I'm going to unmute you all again. Who's going to manage this patient? You exposed the patient. You found out that there was cold leg, blue leg, peripheral pulses absent on patient's right leg. What you want to do? No one wants to manage this one? You're going to let him die? He will lose his leg, Mr. John, poor guy. He's going to lose his leg, guys. Quickly, treat him.
I can attempt. Yeah.
Yes.
Can go for me. We can go for painkillers like probably if it's swollen, and we can start with morphine and heparin, maybe low molecular weight heparin.
Amazing. Great, doctor. You're going great. And what you want to add to the investigations?
D-dimers. D-dimers. In the bloods, probably D-dimers, and investigation obviously Doppler scan.
Yes.
Sorry, doctors. The other doctors, what are they saying?
D-dimers and Doppler look like they're in order.
Yeah.
Okay. Anything else? Any scans?
CTPA.
CTPA.
Okay.
To rule out pulmonary embolism.
All right.
Patient Doppler scan.
Doppler scan. Amazing. That is the most, because patient did not present with acute shortness of breath. So it is less likely that this is PE right now. He has peripheral pulses are absent, doctors. Cold leg, acute limb ischemia. So you want to request a Doppler. Doctors in the UK, if you're coming here, before you get embarrassed at your first job and you say, I would like to order, say I would like to request. Because this happened to me and many colleagues. We were very used to saying order. You request here. You don't order here. All right. Just a fun fact. All right. Okay, doctors. Amazing. You all are amazing doctors. You have so much of knowledge, doctors. All right. Any sites of infection? Ulcers, for example. Doctors, I have another scenario for you at the exposure. You found out that this is a lady who had actually the nurse, when she gave you the handover at the beginning, when she wanted you to review the patient, she told you that this lady is 2 hours or postpartum. And then there was a bucket, or maybe when you move the sheet, you see there's blood everywhere. And this blood is from her vagina. What you want to do now? And what if you did not add grouping and cross-matching earlier? What do you want to do now?
You want to check for the cause of the bleeding, check whether her uterus is well contracted. If not, then you rub off uterine contractions. And then you check if she's if there's any tear in there, and then you repair the tear, and then you set up the blood for her.
Yeah. Okay, doctor, any team that you want to alert at this point? Any teams you want to alert? Two teams that you would
Yes,
like to
the
alert.
O
This
and
lady is
B.
heavily bleeding and the blood is more than 1000 ml.
You want
I think
to
critical care
the
response
obstetrics
team.
and gynecology.
I would like to get ready the operation theater and give a call for the operation theater, and I will arrange some blood for the transfusion.
Who operation theater, doctor? Which department? Are the general surgeon, neurosurgeons, obs and gynecology? Who's scrubbing up?
Gynecology.
Obs and gynecology.
Your messages have to be very clear, doctors. Tell the nurse, can you please alert the on-call obstetric team? Can you tell them about this patient? And who else, doctors? This patient is bleeding very much in the hospital. Which other team you want to alert?
The hematology.
Critical care response team.
Yes, critical care response or major hemorrhage protocol. Can you please activate the major hemorrhage protocol? You know why? The major hemorrhage protocol, every patient has a major hemorrhage protocol, because then the cross-matching, arrangement of the blood and everything becomes quicker. All right. Every hospital has special porters, special team when patient is acutely bleeding and heavily bleeding. If you have activated the major hemorrhage protocol, that whole team will be activated and things will accelerate much quicker than normal. Okay, doctors. So now you know how we have actually covered so many stations here. Hypoglycemia, postpartum hemorrhage. Okay, doctors, this was PR bleed. This was not PV bleed, for example. Which team you want to alert? The bleeding part is the same. Major hemorrhage protocol, grouping, cross-matching, arranging for blood. Which other team you want to involve now? Who wants to be ready with the scope?
General surgical team.
What? General surgery? No.
Gastroenterology team.
Yes, gastro team. Yes, exactly. So gastro should be ready with their scopes. Where is the patient is bleeding from? Okay. All right, doctors, they will give you opinion. At least if they want the patient to go to surgeons, they will tell you. All right. So this is how you manage, you find the problems, you solve the problems there, and then you move on. Yes. Okay, doctors. Yes, you both are right. Okay. But mention the gastro. All right, doctors. So this was end of our session. But at every point, what I will not forget to do is that I will say every point. If I was on airway, I came on to breathing, I will tell my patient that I will reassess my patient's airway. I'll reassess my patient's breathing. If I was on circulation, okay. And if the other team member is there, you can tell them to help you, to alert you if there are any problems. All right, doctors. I hope you have learned a bit from this session. I hope it was helpful. I would like to get some feedback from you if you have benefited, which you can leave the feedback in my group, in my Telegram group. Doctors, I also do run a recorded course, and we have very high passing rate from that course. If at all you're interested, you can ask me. I can leave my phone number there. I can leave my group contact, the group link there as well. So if at all you're interested, do let me know. I also conduct one-to-one mock sessions. All right, doctors, I hope you've all found the session helpful. Any questions at all?
Yes, Dr. Atia.
Mm-hmm.
Please, how many times do you get to reassess the previous parameters? in that station?
So to be honest, it is only 8 minutes and you will not get any chance to reassess. However, if patient is deteriorating at any point, they will indicate it to you. They will prompt you that doctor, patient's oxygen saturation levels are falling, dropping. Okay. Or maybe patient's blood pressure is dropping. Maybe you were on disability and patient's blood pressure started dropping. You want to give another push of fluids, isn't it?
Yes. But
okay. So it's just for the sake of verbalizing, you'll actually not get a chance to reassess it. But as you finish your station and you mention, you start giving the handover to the examiner, just say that, you know, you will repeat the ABCDE until the whatever concerning team has arrived, or the medical emergency team or intensive care unit, whoever you have called. Say that until the team arrives, I will reassess my patient's airway, breathing, circulation again.
Okay, that's fine. Thank you, Dr. Misa.
You're very welcome, doctor. Any other questions at all? One of the doctors said, can I please repeat the fluid correction scenario? Doctor, it's just that you are supposed to give a bolus of 500 ml, but you just have to be careful with the heart failure patients. If at all they have any cardiac history, be very, very careful if a patient who is presenting is elderly patient. So check their cardiac histories, verbalize it, say that does the patient has any cardiac history at all? Okay, because if they are in cardiac failure, you don't want to give them 500. You want to give 250 ml bolus, and then you want to reassess. You want to check their chest again. You want to auscultate it. And even before you give the 250 ml, you will say that I will assess the chest if there are any craps, basal craps at all. You don't want to overload a patient who is already overloaded. Doctors, to be honest, you should take the history when you are, when you talk to the patient initially and you say, how are you, Mr. John? And you can ask him that, what is ongoing? He will say, doctor, there's a pain here. Okay. And then you can ask the nurse that, is there anything different on patient's drug charts? Was there any medication started regularly? Any history of overdose at all? Anything different that we can see on patient's notes or patient's drug chart? That's the kind of history that you need. Or you can ask the nurse, or you can ask the examiner at the beginning, any past medical history at all for my patient. Okay, don't try and take history during, because then it's going to be very difficult. If at all you find a Wheeze, for example, say that, did the patient take any different food today? Any new medication started? Because you're thinking anaphylaxis, you're thinking asthma. Is the patient known for asthma at all? So you can ask those questions as you go along. Okay. The patient, for example, you went on to exposure and you found bleeding. You can ask, was the patient on any blood thinners at all? Does the patient has any bleeding disorders? Was there any instrumentation done recently? You can just ask then. Okay. I hope that's clear. All right, doctors. So yes, someone has asked me to leave my group link. I'm just going to quickly leave my group link and also leave myself as well. Thank you for joining, doctors. It was great having you all. If you have any questions about my mock sessions or the Plab2 course that I conduct, you can just ask me. Okay. All right, doctors, just going to share it in the chat. Everyone. Okay. So this is the link for the group. And I'm just leaving my phone number as well in case you need it. So doctors, anyone if interested to know about the course, it's a 17-day course. I literally kind of take you through like baby steps through this Plab2 journey, that, and I give you approaches, how to, you know, approach any type of station. Even new stations become a piece of cake for you as you go into exam, because we go according to approach. We are not those people who will buy hard things. There is logical approach for everything. So you're using your brain cells, you're not using those scripted things, which you will forget anyway if you just go by scripts, which you will forget anyway when you're standing in that overwhelming environment. All right, doctors. Okay, everybody happy? Seems like you guys are. Any other questions at all before I leave?
Great session, doctor. Thank you very much.
You're very welcome, Dr. Tasnia. All right, doctors. Amazing. Seems like everyone is happy. All right, doctors. Best of luck to all of you, and thank you for joining.
Thank you.
Thank you, doctors.
Thank you very much, doctor.
Very welcome, doctor.
Thank you very much. We appreciate you.
Thank you, doctor. Thank you, Dr. Asha.
You're very welcome, doctors. It's a pleasure.
Thank you so
really
much, Dr. Asha. Thank you.
I love helping you all. Thank you.
Thank you so much, Dr. Asha.
It's a pleasure, doctor.